Hello and welcome to the Society for Adolescent Health and Medicine's 2020 Oral History. This is an amazing opportunity for me because I get to introduce Dr. Henry Berman, who is a dear friend and colleague. And I must say that I am honored to be the person interviewing this year. It's the first time I've done this. And I am proud to be among the legends who are those who have interviewed other people, including Dr. Marianne Felice, Dr. Cheryl Ryan, Dr. Dick McKenzie, and Dr. Henry Berman is among greats who have been interviewed, including Dr. Iris Litt, Dr. David Bennett, and Dr. Rachel Levine. And for those of you that are interested, all of the oral histories that have been archived are on the Society for Adolescent Health and Medicine's website. But this particular day, I get to introduce Dr. Henry Berman. Dr. Berman was born in Hartford, Connecticut, went to Weaver High School, the Weaver Beavers, and then went to Harvard, where he graduated in 1961, cum laude, with a degree in psychology. After that, and we will talk about that in a little bit, he went to NYU Medical School and graduated with a wonderful degree in medicine. After that, he did his pediatric residency after doing a rotating internship and then spent some time in Germany. Dr. Berman has had an amazing history of work in health maintenance organizations, including Group Health, which is now Kaiser. But he's also done a lot of educating, both in New York City, in Spokane, and luckily for me, in Seattle, at Seattle Children's Hospital and the University of Washington. Dr. Berman also was able to concisely determine that the interview process for adolescents should be delineated with the HEADS assessment: home, education, activity, drugs, sexuality, and suicide. And we will talk about all of these things throughout the next hour as we bring out from Dr. Berman why he did what he did and how many different adolescent doctors have been transformed with what he has brought to our field. He is very well published, very strong academic publication as well as articles. But most importantly, he's a teacher, a listener, an incredible father, and a wonderful doctor. So without further ado, Dr. Henry Berman. How long were you actually a pediatrician after you finished your residency?
Well, the war is still controlling my life, right? So at this point, I'm finished with my training, but I owe the military 2 years. And I always say I could end up in Fort Sill, Oklahoma, which they call Mama Sill, because everyone on their way to Vietnam was trained there. But if I gave them a third year, I could have Germany. So that seemed like an easy decision. And so this is really the first time I realized I really had never cared for an adolescent in all those years. Sometimes if they were in the hospital, which we call inpatients, which is I hate that phrase, but I never sat next to a teenager. And so that's when my career in adolescent medicine started, in effect. You want the whole story?
Sure, of course.
So my first week, my first adolescent medicine patient was named Bonnie, and she had just been discharged from the military hospital where she'd been for a couple of weeks because she had fallen or jumped, they weren't sure, off a 2-story house and fractured about every bone in her body. No one thought to ask why she did that, because why would that be important? But since I had never talked to a teenager before in that setting, I introduced myself and I said, "So what was that all about?" Which turns out was the best thing for me to say. So she said, "Well, I was grounded by my parents and they didn't want me to see my boyfriend. So I thought if I jumped out of the window, I could do that." I said, "Oh, how'd that work out?" And, "Well, not so well." And then we merged in talking. I said, "Oh, I guess I have to do something here in my brain. So tell me more about yourself, what's important to you." Turned out she's some interest in healthcare. So we talked about that. And then at the end, I said, well, why don't we talk again sometime? And she said that was fine with her. And so I saw her a few times, and this is a small town. The city, Karlsruhe, was a large city in Germany, but the American contingent there was really, that was the head of the education for system. And so 5,000. So it's like a village. And in a village, within 20 seconds, if something happened here, everyone over there knows it happened. So I came to work one morning and they said, Bonnie has run away with her boyfriend. Pretty interesting. And then a few hours later, they caught Bonnie and her boyfriend in Austria. And next, they're in jail. Okay, well, that's happening. And then the night after that, fortunately for me, I was on call because I had a call from her mother and it said, well, Dr. Berman, Bonnie's back home. I want to bring her in so you can tell me if she's still a virgin. Whoa, I knew I wasn't going to do that. But I said, okay, why don't you both come in? So they came in, and I can still see it now. There's Bonnie's mother, and there's Bonnie. And Bonnie's mother and I are going to start the conversation. And Bonnie says, well, there's no point in asking me that question anyway. I was already not a virgin because I was raped when I was 10 years old. I didn't tell anyone because I thought no one believed me. ... Mother says, I would have believed you, Bonnie, because I was raped when I was 10 years old. And I didn't tell anyone because I didn't think they'd believe me. Am I watching a soap opera here? I've never had such, before or since, such a moving experience. But then, being adolescent, we switch in tone, and her mother says, well, Bonnie, I hope you've learned your lesson. It couldn't have been very much fun to spend your 14th birthday in jail. I realized I had to think like a teenager and not like a doctor. So I said, I bet it was kind of kicky, wasn't it? Now she's safe, she's home, she has a story for the rest of her life, how she spent her 14th birthday. So then I said, okay, Bonnie, I hope you've learned, I hope next time you feel that way, you would talk to Dr. Berman first. She said, yes, he's the closest thing to a hippie around here anyway. And I told this story to one of our colleagues just a few years ago. She said, you still are. So,
yes.
Anyway.
Oh my goodness. That's such an amazing story,
isn't it?
Bonnie.
Yeah.
Yeah, we all have stories like that. Those are all informative as to why we made this decision to be adolescent medicine doctors or why it chose us.
Yes.
And as you've traveled around the world and then you landed after Germany, back where?
Well, this experience, I think, for the first time got me interested in adolescent medicine. And it's fortuitous that a few months later, they had sent professors over, visiting professors, and Henry Kemp, who created the phrase battered child syndrome, and was the guest speaker. And he was very famous, of course, and so that was the main topic for his education, and that was very interesting. And then he said, the next topic is adolescent medicine, which I'd never heard of. He said, whenever I give this talk, one member of the audience goes into adolescent medicine. My brain said, that's you. Just that millisecond. There was some fit there, that fit. So then I needed to figure out where I was going to do that. And for personal reasons, there was a commitment to New York City, or New York area. And there was, and perhaps still is, a journal that lists all the fellowships. So I looked up New York City and saw there were 2 fellowships. One was in Manhattan, one was in the Bronx at Montefiore. And to be honest, I prefer Manhattan to the Bronx. I know that's surprising.
So no, I mean, it is interesting. So for those in the audience that feel one way is better than the other in terms of Manhattan versus the Bronx, shout out for Manhattan. So you landed in Manhattan.
Yeah.
With who?
Joan Morgenthau. I looked up in the book. I saw her name. I called. She said, "Okay, come on up. I'll to talk." And right from the first moment, I called love at first sight. She asked how I got interested. I told her this story. She explained what her program was. She asked me what I was interested in. I said, well, contraception, obesity, drugs, medication, drugs, and what was the fourth one? Anyway, and she said, oh, okay. And so she said, the way it's set up, Dr. Hodes, who was the chair, pediatrics, had promised her there'd be a fellowship, but she didn't know where the money was going to come from. But she said, it will be there. So I said, oh, good, well, thank you. When might I hear from you? She said, oh, it's your job if you want it.
Money's coming later.
Yeah.
Huh?
So that was good. So as she described, she said she wanted a very interesting way of thinking. We all think of halfway houses as on your way out of being
Poor or impoverished.
No, done detox.
Oh yeah.
It's after you've been in the hospital, then you're in a halfway house. But she liked the idea of a halfway house into therapy. Mm-hmm. So because it's scary to jump right into a residential center. And so she said, I'd like you to be in charge of developing that. I said, okay, but that sounds more like a job than a fellowship. So she doubled the pay and said, okay. So I really I tell people I had a fellowship, but it really just jumped into adolescent medicine.
Wow, so it was basically you were running a halfway house, right?
No, see, that never happened.
Oh.
Yeah, because we were in a fancy dancy neighborhood, and all of the neighbors in their fancy prep school didn't want all these addicts. They were already there. The addicts were across the street, but they blind their eyes. So they thought we would attract all these addicts. So therefore, we had to switch our whole priority and focus on outpatient only. Another stupid phrase.
Out and in, yes.
Yeah.
So, and how long did you do that? Was it a year?
No, I was there 3 years. Mm-hmm. And November 1st, 1971 was the first day of our new program. And actually recently, I'm kidding. And so, of course, we said, okay, we're open for business for addicts. And guess how many addicts showed up? Actually, we had one. Mm-hmm. And she wasn't from East Harlem.
Oh.
She was a rich kid and learned a lot from that rich kid. But so we sat around for a month or two waiting for the addicts to show up and got none. And we also set up like siblings. So any sibling of an addict was target, and we still didn't have very many. In the meantime, the grant agency said we had to have 1,000 new patients. Okay, where are they going to come from since we had 2? So we had some terrific paraprofessionals, and we had a social worker that mobilized them, and he thought of all kinds of creative ways to attract these kids. So, for example, there are a lot of small after-school groups for kids, and we would give talks there, and they would bring, everything was free, because between the grant and Medicaid, so we're offering free comprehensive medical care. We would go to schools and give presentations, and the teachers could then know where to get their kids free care. And free care at a highly regarded medical center was very attractive. I remember in order to get the attention of these kids, we wanted to give a talk and we wanted them to listen. So we turned it into quiz shows, at first we thought have them raise their hand. No, have to slap the table because they don't raise their hands. Then we threw candy at them. And by the end, they're sitting there sucking their candy and listening. So a lot of those kids came into our program.
And when did you decide, at what point in your career did you decide that we need to have a concise, focused, if acronym-based format for interviewing adolescents?
Well, I didn't know that at first. I started doing it. Then it turned out that's what I was doing. So I'm going to read from things I wrote because they're better than what I would just say. So we now had all these these teenagers coming in for care, and we're all trained in our histories and physicals and the usual. But a lot of these kids were being brought in. They didn't know why they were there. Their parents said, you can get free medical care there. So you ask, what's your chief complaint? And they say, I don't have one. But then there can't be a history of present illness because there's no present illness, or a family history. And they don't know family histories anyway. So you're chugging along and quickly get to a physical exam, which are all normal. And then what do? There's no diagnosis. So I said, well, that's about a 6-minute process, and we can't have these kids come in here for 6 minutes. And then I realized that this is something called social history. And social history is generally something like truck driver, married, 3 children, smokes 1 pack a day, no alcohol. That's for adults. That's a problem anyway, but it wasn't my problem. So I just started to talk. And when I asked my patients about their lives, not their medical problems, where they lived and with whom, how did they get on with their family, where did they go to school, how was their school performance, what might they do when they graduated, I got very detailed answers. Most of them had never met a doctor who was interested in them, not their heart or lungs. So then to get my patients, to get to know them better, I would ask about friends, sports activities or hobbies, how they spent their last summer, where they worked part-time, where they were involved with religious activities. And then, because we were getting them money for drugs, I would ask about cigarettes, alcohol, marijuana, even back then, marijuana, when it wasn't legal, and other drugs. See if they always answered honestly. I would then ask them an even more personal question. Did they ever have a romantic relationship or an intimate relationship? If yes, I asked them to tell me about that person. Depending on the answer, I would ask about sexual intercourse and the use of condoms every time. The structure of the interview had a natural flow to it. I didn't think about it, but that seemed to be the way to do it. And so around that time, there's a physician named Dr. Weed who had come up with a new way of interviewing and organizing medical care and charts. And Joan decided that that'd be good to learn about so we could improve the quality of our charts. And so on the day after the 1972 election, we won't talk more about that, I took a train to Albany because there was a full day program scheduled, and what he called the problem-oriented medical record. In those days, medical records were often very scratchy. The doctor would say, fever better, no pain in knee, and chest sounds normal. That's all they needed to know. But if anyone else wanted to look at that chart, that'd be meaningless. So Dr. Weed realized there should be an organized way so that everybody could follow the information and be good flow. And problem-oriented medical record is organized by what problem. So it could be the same things. Problem number 1, injured knee. Problem number 2, chest pain. Number 3, fever. But then you discuss each one, and you have an organized way of analyzing that. And his organized way was subjective, what the patient tells you, objective, your measurements and testing and all that, assessment, which is what do you think's going on, and then plan. I don't think he even noticed. I know he didn't notice that spelled S-O-A-P. I know he didn't because I talked to him at age 93, and he had been using the word impression instead of assessment, which would be SOIP. Anyway, so the concept of SOAP notes took over the whole field. If I ask a resident, what the problem-oriented medical record was, I say, that's what you call medical record. But SOAP, yes, everyone knows SOAP. So I'd been asking, as I mentioned, questions of teenagers. And I realized if I could come up with an acronym that would cover the questions I was asking, that would improve our ability to teach, organize the way of thinking. So I wrote down H for home. I thought that I always ask these questions, as I mentioned, in a certain order. So H for home, S for school, question mark for everything else, D for drugs, and S for sex. H, that didn't look very good. So I said, I need a vowel here. And well, if I change school to education, H-E, question mark, D-S, I just needed, if I started with a letter A, I would have heads. And the only letter A I came up with was activities for all that other stuff. Fairly recently, a resident said A could have been for all that other stuff. But in 40 years, 50 years, I begged to have someone come up with a better word than activities. And nobody has. So I guess it's activities. So, voila, heads.
Were you surprised at how honest and open teenagers were in answering your questions?
Yes. And it comes from trust. I think that the key elements are caring, listening, and privacy. Lack of judgment. Caring about them. And actually, I have a terrific story. Ross Gallagher is a founder of the field, and so I'm going to read this word for word. I call it the girl with the dirty boots. He doesn't call it that. A daughter had been raising Cain at home. Out late, dirty, refused to bathe, would come in and disgrace the parents in front of their important friends. They came in and talked to me about this, and I said I'd be glad to see her, but she did not sound like the sort of girl who wanted to come in and see me. However, they set a date and they did literally drag her in. There she was in my outer office in dirty blue jeans, hair uncombed, dirty face, filthy fingernails, and dirty riding boots. They had dragged her in. So I greeted her with the usual, hello, I'm Ross Gallagher. She looked at me and said, this is the last time I'll come into this damn place. I often feel that way myself. By that time, we're in the office. So if you can imagine, here's this teenage girl. This is her home experience. Doctors are supposed to be wearing white coats, and you sit down and it's very structured. Here, someone gives his first name, says he would just soon not be there themselves, and it's startling. It's a way to communicate instantly, and he just did it naturally by that time. We'll have to go back and mention who he is, by the way. What's cooking here, I said. Whose idea is this visit, as though I didn't know? Whose idea? That old battle axe. And then she was off. And she went on and talked for an hour. Well, why don't you drop in a few days? She said maybe she would. As she was going out, she said, I'm sorry about these boots. They dragged me down here. I didn't have a chance to clean them. The boots were important to her. She didn't want me to think that she went around in dirty riding boots. She hung her pajamas in the middle of the bedroom floor, but everything in the tack room was just right. The next time she came back, she had a dress on, an index that maybe things were better. What did I do to get the girl to come back? I didn't do anything. I didn't say, what do you mean coming here dressed like that? I didn't say, what is wrong? I didn't pry. I didn't seem to be shocked or upset by her foul language. I tried to be more interested in her than in her language or her clothing. Perhaps she felt this. I think that story is half of adolescent medicine. It covers so many things about relationships, how a doctor can encourage information that would be difficult for patients, just listening, just, so I think that's worth the word for word.
That's a beautiful story. That's a beautiful story. And you do mention in your book, which we're going to get into in a little bit, about the concept of adolescent medicine being a vocation versus a profession, or a combination of both.
But the only time it had been published was Joan put on a symposium, and this is in 1974, was a very rare specialty, so people came 100 miles away to learn. And so there were 8 talks, and I did 2 of them. And the first one was interviewing teenagers. So, of course, I talked about heads. And then that got published, but it was published, self-published by Joan. So it's pretty obscure kind of thing. And it turned out that there had been Eric Cohn was a physician at CHLA. It's not Children's Hospital of Los Angeles. There's no of. And he was planning a new program looking at the difference between runaway kids and homeless kids. Runaway kids had a home that they weren't in, and homeless kids never had a home. And he wanted a structured questionnaire, and figured he didn't want to invent it. And somehow, I don't know how, he found this article. But he wanted to modify it a bit because of his population, so he added another S for suicidality/depression. I was going to say. So he was working with Richard McKenzie, who was one of the early leaders. He was the 10th president of SAM. And I'm going to read what Richard wrote. One of the things I really felt strongly about in the early days was a physician in adolescent medicine should not only be accomplished in knowing how to take care of ills and illnesses, but should also be effective in understanding the psychology of that age group. To be able to do counseling for kids with psychological crises or who are caught up in social crises like living in the street that related to their risk profile. The heads approach gave us a much broader picture of what their needs were. We could use this to teach doctors how to work with adolescents.
I'd like to spend a few minutes at this time talking about your book, Teens and Their Doctors, The Story of the Development of Adolescent Medicine, which is an incredible book written by Dr. Berman, along with Hannah Dashevsky, his co-author. And I've read it through multiple times, again, while preparing for this interview. But what made you, what was it that was the driving force to Dr. Berman to put this dream into reality? Why did you do this?
That's a good question. A lot of times when we're doing something, we don't think about why we're doing it. Part of it, by this time I've been practicing adolescent medicine for longer than I hadn't been, half my life. And I know that people didn't understand it. And doctors in particular didn't understand it. And it was such an important area that I thought if I could explain it in a way that interested them and that gave them a direction, that would really improve the ability to both improve their pleasure in taking care of adolescents and improve, therefore, their ability to take care of the kids. The title of the book is the Story of the Development of Adolescent Medicine. And I got that title. I think this is interesting. There's a writer named Richard Kearney who, I'll quote a bit here, telling stories is as basic to human beings as eating. While food makes us live, stories are what make our lives worth living. They are what make our condition human. And that really struck me. And that led to my realizing that the way to write this book was by learning people's stories. And I interviewed, or Hannah and I interviewed, over 80 specialists in adolescent medicine, all of whom trained under the pioneers of the field, and got just some of the most amazing stories. And some of those stories, for example, we just talked about listening, and I'll find the thing. Where is this one? Early things. Yeah. Robert Hobby, one of the early specialists in adolescent medicine, talking about listening. He talked about a patient that he was seeing with type 1 diabetes, and he had visits every couple of weeks, and he just felt they weren't going anywhere. And he finally talked to his preceptor, who said, you need to so we told the preceptor that it made him feel his appointments were a waste of time. And his preceptor said, well, tell her that. So next time I employed his strategy, and that was the beginning of a really productive doctor-patient relationship. During our turnaround, she mentioned that her previous physician listened but did not hear, which I think right there is half of what you need to know. And I think that's very common with physicians, that they're talking, I think within the first 10 seconds of a visit, a doctor's already talking, whereas Ross Gallagher, it took him an hour to start talking. So I think that's a terrific example right there of
what we do.
What we do.
Now, my turn. I have a few more questions.
All right, you're allowed.
So we left off that you, after being in New York, moved to Spokane.
Mm-hmm.
And what did you think of living in the Northwest versus living in New York?
Well, we grew up in New England, and Louisa and I, Connecticut. And New England isn't that different from Spokane. Well, forget about New York.
Okay, fine. Really? You think Connecticut is the same as the Northwest?
Spokane, that part.
Okay.
Not Seattle.
Okay. And so you lived in Spokane, and during the time, where did you work when you were in Spokane?
I was running a branch of group health over there.
So what does that mean? I mean, that's a kind of a different job. Did you deal with many adolescents when you were running that institution?
Well, I was a medical director at first, and continued to see patients like a half a day a week or day a week. Then I became the chief executive officer. So I was mainly doing the business side, but I was helping develop programs. We got an award actually from for adolescent medicine program for a national organization. And in particular, we had a terrific family physician who created a program for teenage girls who had a baby, and it was called High Hopes. Mm. And the data show that a teenager who has had one child can manage if they have two children, then they never go anywhere. So the idea was to prevent that second pregnancy. She had a walk-in clinic, and we did an analysis. She had a terrific success rate. So all someone had to do was say, I want to do that, and I said, go do it. So I had these terrific staff, and they came up with a lot of programs that helped a lot of kids. Did
you feel that your training in taking care of teenagers helped you deal with adolescent behavior in adults?
Well, here and there, I guess.
I mean, I don't mean to say that
I know
there's
that.
anything wrong with adolescent behavior, being an adolescent doctor too. But
Well,
there
the
are times
dynamics. Yeah. Well, who's the adult and who's the teenager?
Right.
You mean?
And when people
Yeah.
regress to the mean, you think.
Yeah.
So I mean, I feel that way with some of the programs that I lead. That if I have someone that's acting in a petulant way, I think, I'm going to pull my adolescent hat out. And
Right.
just
That's a good idea.
listen. And so then you were in Spokane, and then decided to come to Seattle. What made you do that?
Well, what made me do that, of course, is our grandchildren had moved to Seattle. So once they were here, we wanted to be with them. And I'd started a small practice in Spokane, day and a half a week of behavioral adolescent medicine. Some very interesting cases. I chose 10 to 25, so I had a wider range. And then, so I figured, well, I'll move to Seattle and create a practice there also. But I was trying to figure out how I could get referrals. And I hadn't met Mark Smith, but he was in Spokane to give a talk. And I went to his talk and told him what I was doing. He said, well, the first Tuesday of the month at 7 in the morning, you can come to this meeting we have. And fortunately, we had a condo in Seattle, so I could fly over the night before and never miss the meeting, 7 a.m. first Tuesday. So I got to know all of our wonderful staff, and they got to know me. And then Mark announced he was retiring, and he was 0.3 clinical. So I think they originally hoped to have a replacement ready, but they didn't. So they were offering a 3-month 0.3 position, which no one else in the world would have possibly applied for. But that was perfect for me. Okay, I'll come over 0.3 and get settled in. And then it became 6 months, and then it became a year. In the meantime, Leslie joined us, and I always say she and I are twins separated at birth. We just hit it off like that. So she wanted me to stay. I said, it'd be half time, that'd be fine, and the rest is history.
The rest is wonderful history, and I actually honestly can remember, well, a couple of things I remember. The first of which is I think you were still in Spokane, and I didn't know you yet, but you were on the SAM listserv.
Oh, yeah.
And you were had a patient die by suicide.
Yeah.
And I remember seeing Berman. I remember seeing your name come through on the listserv because it was challenging, and you were looking to see if there's anyone else in the SAM family that had been through what you had gone through. And you honestly had pretty much poured your heart out. I remember that, and having never met you, and I remember thinking, who is this wonderful, wonderful man? And and wow, this must have been really challenging for him. And you got so many people responding with similar stories or just with support. What was that like for you?
So I was just, in particular, why I reached out was my patient had shot himself. I still remember that. And I got a call from, here I am, I give him SSRIs, and I'm figuring I'm the killer. I got a call from his father, who said he had a sister who was 13, and would I be willing to see his sister? And that's why I reached out. Does anybody have any experience with that kind of thing? And I met with a girl who's an amazing kid. And we talked about how she felt and what was happening. And she had questions. I did my best. And then she's willing to come back again. And in the interim, there was another suicide in the community. And she said that one of her friends didn't know what to do with herself. He said, well, find a psychiatrist and tell him how you feel. So that's what she got, I got out of that. And then in the meantime, I had met some people over here who'd had a pretty similar situation. And we ended up creating a whole program for a SAM presentation that interviewed parents who had lost their kids, and that I learned later on that Leslie had been, I'd never heard of Leslie at the time, that she had been at that talk. It was unusual for Sam to have that that kind of thing. So yeah, so that was my first involvement in that sense.
Right, and I had never met you, but I was, obviously all of us in the Society for Adolescent Health and Medicine go on the listserv and devour it sometimes when we want support or help or just a validation that we're doing the right thing. And that you were asking for help was amazing, and then to have you work with us was just such an honor for me, because wait a minute, this is the same guy that I sort of worshipped from afar, and here you were working with me. So, and your legacy in terms of asking about suicide lives on, and I literally was just giving this lecture to medical students, but you have to ask, and it doesn't make people more suicidal to ask that question. And yet all of us know someone who's died by suicide, and we just want to make sure there's no more. So, and thanks for sharing that. That was a tough story. I know also there are a couple other questions that our audience is going to want to ask, one of which is, who was your most memorable teacher?
My whole life.
It can go all the way down to kindergarten.
All the way down to kindergarten. B.F. Skinner.
B.F. Skinner? Really?
Yeah.
He lectured to you?
He was the chair of the psychiatry department at Harvard.
Oh my goodness. What was that like? He
is an interesting guy.
What do you mean?
He has a remarkable mind, and he changed this country, changed his world with his ideas of conditioning, and he's really misunderstood. He just understood how you can influence behavior by reward, not by punishment. Punishment doesn't do anything, by reward. So that it helps you, if you understand that, as a therapist, as a parent, as a friend, that you don't criticize, you don't blame, you kind of build on people's strengths. And he taught pigeons how to play ping pong. You find that on the video. He has trained pigeons to play ping pong.
Oh my goodness.
Now they pet him. How does he do that? And that's the humorous part. He just had an imagination. He understood people, and was just very dynamic. So it's kind of like that changed my life, my way of thinking about things. I did a rat experiment using his system.
Another question is, who was your most memorable patient?
Let me see. I don't know if she's the most memorable, but the one it goes with the Skinner thing here. It's a girl that we saw here. I walked in. I use, as we know, patients, both parents, but kids are intimidated. They're in a doctor's office, so a lot of times I make stupid jokes to kind of, I hope, relax them. So, the pile of questionnaires that we have, they're all filling out. So I walked into the room and I said, "How are you doing on your paperwork? I can get you more if you want." And there was a 6-year-old who said, "That was a joke. I don't understand jokes." Ooh, sounds a little autistic there. Well, as we know, not all, but many kids with autism have a particular thing they are obsessed by, and hers was B.F. Skinner.
Wow. Oh my goodness.
And she finds someone that's studying her B.F. Skinner. She calls me her pigeon doctor.
Pigeon doctor. Of course you are.
The reason it's a pigeon doctor, so Skinner created something that would have saved thousands of lives during World War II. And it had to do with training pigeons to do certain things, and it really worked. But it was all set to go. It was a way that they could bomb a Japanese boat, is what it was. Just losing the life of a pigeon. And there's an article about it, 10-page article. And they made the mistake that when they were presenting it to the congressional committee, that they could see it was pigeons. And then they laughed. So she knew about that also. And she drew a beautiful drawing of a pigeon and me that she gave me.
Oh my, that's a wonderful
so that was
story. Connects it all.
Right.
So our next part of the interview, what I'd love to ask you, Henry, is what do we actually do as adolescent medicine doctors? What does it mean to be an adolescent medicine doctor?
Well, I get approached by people that said, what do you do? Every pediatrician sees teenagers. And I say, yes, so what's different? And what I say is, well, we see the ones you send us for eating disorders and complicated things, and that satisfies them. But that's not really the answer. So I have an anecdote from Leslie Walker. Late on one Friday afternoon, I saw a 17-year-old girl who was referred to me because her legs were swelling. Also, she had gained 30 or 35 pounds over the past 6 months. I asked her if she was pregnant. She said she was 30 weeks pregnant, but no one knew that. She was afraid to tell her mother. She would kill herself rather than have her mother find out. Her plan was to go to the ER when she went into labor, have the baby there and give it up for adoption on the spot. I pointed out that this was not a good plan. For example, her water might break in class, and then what would she do? I made her promise to tell her grandmother. I worried about that all weekend. On Monday, she arrived with her grandmother and her mother. After she had her baby, her mother and grandmother helped take care of her daughter, and she completed high school. The last I heard of her, she was in college. That is what we do.
That's a wonderful story.
Isn't it? Yeah. So in the process of writing my book, I felt that the answer of what do we do was really what was missing. I needed to figure out how to answer that question. And I came up with no one answer, of course, but I came up with 3 elements that I think are what we do. So one is we are a secure anchor. In 1953, British psychoanalyst Donald Winnicott published an article that used the term transition object. The transition object is a tool that allows a child to let go of the mother and develop a much more independent existence. It can take the object anywhere and receive a quick dose of comfort whenever it feels anxious. The classic example is a stuffed animal, a rabbit or a bear. The toddler takes everywhere. It helps in transition from wakefulness to sleep, mother to babysitter, home to preschool. In 1974, Michael Murray suggested a therapist could play that role, transition object for their patients. Quote, by allowing a real and independent relationship with a reliable adult and supporting morale in the struggle for separation and autonomy, they become a secure anchor. They're always there, always supportive. Each of us had a patient or two, I think, that used us that way. And I have a story about Robin Beach. Was a secure anchor to one of her patients. One was a 15-year-old girl, D was a 15-year-old girl who I followed for 4 years with problems with family issues and anxieties that adolescents face. Over the years, such problems as menstrual cramps progressed to sexual decision-making, and the wisdom about an old boyfriend were discussed. 40 years later, I was a patient at the University Hospital, and one of the nurses sat down next to me. She said, "Dr. Beach, there's no reason you should remember me, but you were my doctor in the adolescent clinic when I was a teenager." She wanted me to know how important it had been to her to have a doctor she could talk to and depend on. There were times I just didn't think I could go on, but I knew that that next appointment was scheduled with you, and that's why I'm still here. So that's being the secure anchor. Then the next element is that we're askable. And in 1977, two therapists coined the term askable person. Skill and sensitivity may combine to form the askable person. Someone who, more by behavior than by information, conveys an openness, acceptance, and caring that makes it easy to come and talk. The askable person listens well, values the opinions and concerns of others, and is not afraid to say, "I don't know." So we have the askable. We have to have patients that feel they can say anything. If you remember the Ross Gallagher story we talked about earlier, when she said, "This is the last time I want to be here," and he said, "I feel that way myself," right away, she knew this was someone she could ask. Someone that said that. He knew that, she knew that. So that was the critical element really in that story. Next page. Get your editing, won't be a problem. So the head's interviewing process is structured to maximize askability. The physicians listen without judging, encouraging the team to trust him or her. If the interview elicits a significant concern, the team appreciates the opportunity to unload their burden as opposed to holding back, not trusting the physician. And I have a story I'll be telling you about that. Very interesting article was published in 1954 by a British surgeon named Sir Heneage Ogilvie, one of my favorite names. He actually was a physician in both World War I and World War II. That's how we got to be Sir Ogilvie. But so he wrote an article called Ephebos. Ephebos is an Italian youth, an Athenian youth, and Ogilvie says, "Youth is a time of adventure. The Ephebos, who has hitherto been sheltered and guided," these are upper middle class, upper caste, "by his parents, fed by romances in which he identifies himself with a hero, sets out with an exaggerated idea of his own importance. He has set up his ego as something unassailable. He suddenly finds it bumping up against countless other egos, equally important to their owners. And in the clash and conflict of egos, it may survive in a very much its original form, with the corners rounded off, may be withdrawn, reconditioned, and reissued in a very much more serviceable form, or it may be damaged beyond repair, in which case he must put up an elaborate facade to hide its deficiencies. Functional illnesses of all kinds are found in young people, particularly young women who have just plunged into the seas of life and found the water too cold." So Leslie, in her story, saved a 17-year-old girl from the cold seas of life. And I have a patient I think I did that for also. Jason was referred to me after a visit to the emergency room. He'd been riding the back seat of his father's car, and he took a bite from a Snickers bar. He had an anaphylactic reaction and was driven quickly to the hospital. During his visit there, Jason confirmed that he had known that he was at risk if he ate peanuts, but he was not trying to kill himself. The staff did a thorough analysis using a department checklist and came to the conclusion that indeed there was no evidence he had been suicidal. As you know, for our hospital staff, their standard thinking is if we can't figure out what a patient's problem is, we refer to adolescent medicine. So, Jason showed up in my office. The note from psych was very thorough, but did not come to a conclusion. So, as usual, I used my head's assessment. Things at home were fine, things at school were fine. Activities was next. I think most of us think the most important element under activities is friendships. So when I got there, I said, tell me about your friends. And he said he really had one close friend. It was a girl from school. And I asked him about that, and we could talk about anything. It's the only person he could share with. It's very important to him. And I asked him about, does he ever talk with his parents about his concerns? He said, no, they're always fighting. I asked him, was there any violence involved? He said there was. When I asked if his father was hitting his mother, there was a brief pause before he said no. I then asked him if the father was hitting him. He acknowledged that that was the case, most recently with a chop to the side of his neck, which could have been fatal. Of course, I paused my interview and found our social worker, Eric, who does everything, who called CPS immediately and then sat down to talk to Jason's parents. I picked up where I left off, looking for more information about his relationship with his father. As it turned out, Jason had taken the bite of the Snickers the morning after the dangerous blow. He was trying to kill himself to get back at his father. So I may have saved his life. He had plunged into the cold seas of life. So being a secure anchor, being askable, and at times intervening in critical situations, that is what we do.
Thank you, Henry. That was wonderful.
Thank you.
So if you had 2 or 3 sentences to tell future adolescent medicine doctors about the field, about the joys of being in the field and the future of the field, what would your sentences be?
Love your patients. That's what it is. That's what they need. That's what you need. And as we know, we don't choose adolescent medicine, it chooses us.
Yes. So. Thank you, Henry.
Thank you very much. One of my patients tried to kill me.
Okay.
Now, most of the time this went very well, but in an adolescent medicine setting, one of my patients tried to kill me. She came into our facility, hand raised, scissors. I want to kill Dr. Berman. I hid in the nearest room, which I was embarrassed by later, but Joan said that was the right thing to do because I was the target. If I weren't the target, then of course I should have been the person who intervened. And then the next morning, the patient was sitting next to one of our nurses, and she said, I had a bad day yesterday. I tried to kill Dr. Berman. Take a break there. One of my favorite lines ever.
Favorite line, he said.